Go.
Okay. So I'm Steven, and I'm doing common concerns for endocrinologists as my main topic. As a disclaimer, some of this information in this presentation is from outside sources, as I did plenty of research. I did not come up with all the information on my own. So all about ISM. Independent Study Mentorship is a course which allows students to focus on a particular career field and to receive guidance from a professional in that field. Unfortunately, due to the COVID-19 pandemic and distance, I was unable to meet my mentor in person, but I was able to interview them through emails and calls to guide most of my research. For our course requirements, we have to do activity logs, journal entries. We have to create our own website, which I actually have a QR code for in case later we want to go through that. We had to do artifacts, which are common tools that a professional in that field would use day to day, and a semester project with a tangible product, which is what I'm doing today. So for my career field, I used the same mentor that I did last semester, which was an anesthesiologist, but as this semester I did endocrinology, I was able to ask him a lot of questions about biochemistry in general, and since he had a lot of experience within that field, he was able to guide most of my research. So why is my topic relevant to me? I want to focus on this career to be more prepared for the pharmacy technician class I'm taking next year. I also want to have a future major in biochemistry to fulfill my, and also I want to fulfill my interest in pursuing this specific field, as I think it's something I might want to pursue in the future. So my topic is going to be going over 3 different points, which are methods of drug administration, Graves' disease, and polycystic ovary syndrome. Okay, so why are drugs delivered differently? Well, a few factors to consider when giving drugs to a patient is the pharmacokinetics and pharmacodynamic profile, which is a lot of chemistry jargon for basically saying the molecular size, the polarity, the concentration needed, its charge possibly, how it interacts with other cells, its targeted pathway, convenience and cost to the patient. Either is it self-administered or is it administered by healthcare personnel, and potential complications of each method, as each one is completely different and has a number of variables. So there's 2 different routes. There's the enteral route and the paternal route. So the enteral route is the oral, buccal, and rectal. According to Oxford Languages, it is involving the passing through of the intestine, either naturally through the mouth and esophagus or artificial opening. So it needs to pass through thin tissue lining, but it can require larger molecules, as absorption can go faster through thinner lining. The concentration of drug is not always fixed, as first pass or liver filtration can reduce drug concentration heavily. It's very convenient to patients and typically given orally through pills. Same thing for the rectal method, they'll usually also provide pills. Buccal tissue is not as permeable and is slower to absorb, but bypasses the first pass effect. So typically when they're going to give you something buccally, they'll give you it because they want it to have a long sustaining effect, but also because they're worried about the concentration amount. As you know, if they give you something through like a pill, it doesn't have to be as exact, but if it's buccally, they want it to be as exact as they need it. Rectal tissue is very permeable and is rapid to absorb, but patient may receive some discomfort, typically used for patients with gastrointestinal motility problems and those receiving hospice care. So if you have a problem swallowing or a problem actually taking it through your stomach to your small intestine where it is absorbed, they might take the shorter route, getting to you rectally.
Also common in pediatrics.
Yes. Is the simplest route taken and has little to no complications associated, often can be self-delivered. So the second one is the peritoneal route, which includes intramuscular, subcutaneous, intravenous, intradermal, and a lot of other methods that I'm not including. The methods that I'm talking about today are administered through injection through a skin layer, puncture with a syringe and needle. They are the largest molecules, as they do not need to pass through as many barriers to enter their desired site of reaction. So typically, if you're wanting to have something through your enteral route, it has to absorb into the desired site, versus here where you can inject it exactly where you need it to be. It's administered to many different layers depending on the drug's polarity, absorption rate, molecular size, and pathway. As I mentioned earlier, the pharmacokinetics and pharmacodynamics. So the intramuscular injection is given when oral drug absorption is erratic and high first pass metabolism. It is fast and quick absorption into the bloodstream, also administered for high protein synthesis. So one of the examples that is most common is vaccines. So when you have to produce antibodies, which are proteins, you're going to inject them into into a part of the body that can synthesize the proteins the fastest, which are typically the muscles of your gluteus maximus or of your biceps. Usually your shoulders are the most common. For instance, like the COVID vaccine, will typically inject it into your bicep. So the subcutaneous injection is used for drugs that are very large and must be absorbed slowly. This layer also has less blood vessels, so it's desired rather easy to self-administer. So insulin is usually given through subcutaneous injection into adipose tissue. Typically this is done because insulin needs to be long sustaining. So if they put it directly into your vein, it's going to go very fast. But they want something that'll last a while longer, not something that'll be absorbed rather quickly. So intravenous injection is directly administered to the bloodstream. Exact concentration and rapid effect is needed, typically selected for drugs that are poorly absorbed, given to patients with altered mental status or unable to take oral medication. So for instance, if you have a patient who has an altered mental state and they need to have a sedative, you need to make sure that they receive the drug as fast as possible, because if you have that for a sustained amount of time, you have to wait for it to absorb, or you don't know the complications that could happen if you have the wrong concentration. So typically they'll do intravenous for patients who have altered mental status or similar things, so that they can make sure that they're sedated properly. And then intradermal injection is typically used as a body reaction and sensitivity test by anesthesiologists and allergists. It has the longest absorption time of any parenteral routes. So intradermal injection, it's the top layer of the skin, which means that it has to absorb through all the layers before it gets to the veins. Typically when allergists are giving something through this, they'll make sure that it's in the skin for long enough that it can react, so that they can know that if you have an allergy to medicines or different things. Same thing for anesthesiologists when they might give local anesthetics or other things to make sure you don't have a reaction or any kind of complications. Complications include site infection and trypanophobia with patients, although these are very uncommon. So trypanophobia is the fear of needles, which is a very common thing for a lot of patients, but it's not as severe where it needs to have an alternate method taken. So my last one is transdermal drug delivery. Although this is a form of the parenteral route, I wanted to give it its own page due to how novel it is and how important it is for endocrinology specifically. It is a painless method of delivering drugs systematically by applying a drug formulation onto intact and healthy skin, according to PMC Public Health. So it's a very novel delivery method and is receiving much research currently, as skin is the most accessible organ and delivery is non-invasive. Currently, there are less than 100 FDA-approved drugs, which means that it's the drugs that are approved need to do lots of research, or they need to be very specific, as they are the smallest molecules and non-polar to pass through the many layers of skin for either drug absorption into the bloodstream or particularly into the skin. So the reason why they need to be small and non-polar is because the cellular membranes are also non-polar. So in order to go through all the layers of the skin, they both need to be small so that they can fit through all these different molecules, but also non-polar so that they don't have any resistance against them. So there are two forms. There's patches with a reservoir and a gel-like solution that has the drug dissolved inside. So either they can apply the gel, just smoothing it on, or maybe sometimes they'll offer a spray solution. So this has a very future possibility to reduce medical waste, increase self-administration of drugs for long periods of time, reduce disease transmission due to shared needles or other similar things. However, there are strong fears of drug abuse and overdosing by patients due to their ease of application. So the three examples I provided were nicotine, testosterone, and fentanyl. So testosterone is one that's used very widely today, due to, usually in a gel-like solution, because of how easy it is to apply. But nicotine and fentanyl, they have a lot of worries over them due to their ease of application, meaning that if a patient gets a hold of too many at the same time, and since they are widely addictive medicines, if they apply too many patches and they don't understand how they sustain over time or how much they need, they can easily overdose or have many different complications that many healthcare personnel would most likely want to avoid. So my second topic is Graves' disease. So Graves' disease is an immune system disorder that results in the overproduction of thyroid hormones or hyperthyroidism, according to Mayo Clinic. It is the most common cause of hypothyroidism for 60 to 80% of the people who have it. Often found in patients with positive family history, women, and people younger than 40. There are several environmental factors including stress, smoking, infection, iodine exposure, HAART, which is a treatment of retroviral antibodies, interferon alpha, which is a cytokine, can trigger response in genes susceptible to cause Graves' disease. So I included two pictures here to mostly explain it in a more advanced way because I couldn't find a picture that fully summarized what I wanted to explain. So this entire thing is a negative feedback loop with the pituitary gland and the cells of the thyroid. So what typically happens is the pituitary gland will signal that it needs T3 and T4. So it'll produce TSH to the receptor that will stimulate the process of creating it. But something that may happen is that your immune system, specifically any antigen presenting cells or macrophages or similar things, may absorb any peptides that are part of that receptor and then may produce, may trigger plasma cells to produce antibodies that may inhibit the ability for the pathway to be turned off, meaning that your thyroid cells are continuously producing T3 and T4 and overgrowing when your pituitary gland probably doesn't need them to be doing so. There's physical signs including tachycardia, systolic hypertension, potential heart failure, atrial fibrillation, tremors, hyperkinesia, hyperflexia, warm skin, pulmonary erythema, hair loss, and altered mental status. Graves' ophthalmopathy and Graves' dermopathy. So ophthalmopathy is the thing I have over here. It's when 30% of people with the disease express this specific sign. It's caused by TSI from cytotoxic T lymphocytes that trigger fibroblasts and pre-adipocytes, resulting in inflammation and growth of extracellular muscles, connective, and adipose tissue. So typically when they're trying to fight off what they perceive as an infection, as it's an autoimmune disorder, they'll typically stop the negative pathway from canceling itself, meaning that a lot of this tissue will continue growing because it thinks it's being damaged. Another symptom is many elderly show signs of apathetic thyrotoxosis when it is atypically presented. So,
attention chargers, bus 126 is at the back of the line today. Again, bus 126 is at the back of the line today. Have a great weekend.
So typically, when you have T3 or T4 being overproduced, it'll make the patient have a hyper-aware state, and they'll be overly active. But in some elderly, they actually show signs of being apathetic, which is the exact opposite reaction as most patients have, which means it's harder to diagnose. So often early diagnosis is key to reducing complications and harmful expressions. Blood tests for abnormally low TSH, radioactive iodine uptake, ultrasound, CT, and MRI imaging, which those three are shown to see the shape of it, to see if it has any goiter. Many treatments include reduced thyroid hormone synthesis, include anti-thyroid drugs which block TSH, and a thyroidectomy. Of course, the second one is highly not recommended, as it can cause many complications throughout the patient's entire lifespan. So my final topic is polycystic ovary syndrome, or PCOS. Polycystic ovary syndrome is a condition in which the ovaries produce an abnormal amount of androgens, male sex hormones, that are usually present in the woman in small amounts. The name polycystic ovary syndrome describes the numerous small cysts or fluid-filled sacs that form in the ovaries. However, some women with this disorder do not have cysts, while some do, according to John Hopkins. So the ovaries regularly produce many different kinds of sex hormones, and in menstruation develop and release eggs. So this is a result of various environmental and genetic factors, but the overall cause is unknown. It is characterized by an increased androgen levels, polycystic ovarian morphology, or the presence of cysts being shown, arrested follicle development, and ovulatory infertility, high insulin and insulin resistance, and oligomenorrhea, or less than 8 cycles per year. This affects 5 to 10% of reproductive age women in the U.S. and is one of the most common causes of female infertility.
In your research, did you see if, did you notice that there was an increase in PCOS? Like, has it been increasing in diagnosis over time, or did you see anything of that? I was just curious.
I didn't notice anything like that, but I don't think I would be surprised as
I was just considering like environmental factors.
Yeah.
I was just curious.
I mean, as over time, there's been a lot of problems with sex hormones. Over time, with a lot of the population due to a lot of environmental factors increasing.
Right.
So I wouldn't be surprised if PCOS, like the case
More
amounts,
common.
have been more common.
Just curious.
Yeah. So early diagnosis is important to provide treatment, prevent morbidity, and assign future risk of infertility, cardiovascular disease, and type 2 diabetes. Symptoms include irregular menstruation, ovaries with many cysts, excess body hair, weight gain, acne, and male pattern baldness, as well as infertility. It can be hard to recognize in adolescence as the symptoms are like that or like puberty, and there are several different criteria methodology specific for adolescents. So some of the methods to diagnose include anti-Müllerian hormone, or serum AMH, as anti-Müllerian hormone is found in increased levels with people who have PCOS. Using ultrasound technology to count antral follicles, and blood testing for biological or clinical hyperandrogenism. When diagnosing either hyperandrogenism disorders such as NCAH, Cushing syndrome, tumors, thyroid diseases in relation to drugs, etc., must be eliminated to make sure that PCOS is the main cause of the hyperandrogenism. So changing a patient's diet and activity may alter their insulin levels and may help ovulation. Other treatments include cosmetics and hair removal for many of the symptoms and signs, medications that increase ovulation. A complication is ovarian hyperstimulation, which means that you go from one end of the spectrum to the exact opposite. Birth control to reduce androgen levels, fertility treatment and assistance. One of the most important things is for doctors and physicians to know if their patient has a possible future of wanting to have kids, as it'll alter the methodology. Because increasing ovulation may help you have kids in the future, but many other medications that may help you with a lot of the symptoms may actually hurt your chances of having kids in the future. So for some of my artifacts, I chose DNA testing, urine testing, and blood testing. So typically all of these are used to see all sorts of kinds of diseases all over the place, because endocrinology includes such a wide spectrum of biochemistry that all three of these are used very commonly. Another 3 diagnosing methods are ultrasounds, MRIs, and x-rays, which are all used to see the shape of different organs and tissues in the body, as the biochemistry will affect their shape if they've got a goiter, which means they're a bit bigger, or if they're going to reduce in size, tumors, other things like that. So I have an IV bag, a patch, which is another example of transdermal drug delivery, a syringe and needle, and some ointment, which may be prescribed as another example of transdermal drug delivery. Product. I will show a demonstration of how to use a syringe and how to target specific desired site of reaction. So I have my syringe here. So typically what you would want to do is that you want to extract the exact amount that you want from the syringe using the plunger. And when doing that, you have to make sure that you're going slow. Typically what a lot of doctors will do, especially with vaccines, is that they'll squirt a tiny bit out to make sure that there isn't any oxygen, because if you insert that into any part of the body, it can cause a wide number of problems, including blood clotting or like a number of things. So typically there's 2 different things you want to consider: the angle of which you inject and also the site of injection. So if you're wanting to do intramuscular, you'll typically do it in the bicep, or you'll typically do it in the gluteus maximus, as I mentioned earlier, because those have the largest and most accessible muscles. Or if you want to do into adipose tissue, you typically do it in the stomach, as a lot of insulin patients do. versus if you want to do intradermally, you have to make sure that you hold it very close to the skin, and also you want to make sure you have a very parallel angle with the skin, so you don't pierce anything further. If you want to do intravenous, you want to hit the major veins, which typically they'll use the veins right here in your elbow. They'll have a more increased angle, and when you inject, you want to make it very slowly. Typically, it depends on the site of reaction, but for many, you may want to hold it there, including for subcutaneous, especially when you're delivering insulin. They usually say you want to hold it for about 10 seconds, because you want to make sure it fully absorbs into the skin. And if you pull it out too fast, blood or other adipose tissue, or even the insulin itself could come out. So for my conclusion, I really hope to have some foundation with the field of biochemistry and how it applies to the administration of drugs, whether it's for my future and next year in pharmacy technician or my major after I graduate. So I want to say thank you to my mentor, James Stockman, my parents, Lori and Steve Engelbretson, Ms. Daffern, my ISM teacher, and of course, Ms. Jones, who's my evaluator right now. Here my works cited. So any questions?
No. Wow. No. You covered everything that I would have asked.
So that's it for my presentation. I can show you my Weebly.
It's 21.
Okay, I think that's it then.